Hello, this is Eric Strong from the Palo Alto VA and Stanford University. This is the 8th lecture in this course on understanding ABGs, and the topic is elevated anion gap metabolic acidoses. While lectures 3 through 7 focused on providing a collection of rules for determining a patient's acid-base status, lectures 8 through 12 will discuss the differential diagnosis for each of the 5 general pathophysiologic states of acid-base balance and to provide some insight at how to establish a specific diagnosis in an individual patient. This particular lecture is the longest of the course and will include a fair amount of biochemistry that may be intimidating. Please do not bother memorizing specific chemical structures or enzymatic pathways. I will review these here because it helps to solidify your understanding of which medical conditions result in which acid-base problems. However, knowledge of which hydroxyl group bonds to which carbon atom is not going to be important at the bedside. The specific learning objectives of this lecture are to know the differential diagnosis of an elevated anion gap metabolic acidosis and to be able to identify the specific etiology of an elevated gap acidosis in individual patients. For details on how the anion gap is measured and how to identify the presence of an elevated gap metabolic acidosis, please review Lecture 5. The differential diagnosis of an elevated gap acidosis is fairly long. In order to remember them, several mnemonics have entered into common usage. In general, I hate mnemonics, but one for elevated gap acidosis is so prevalent that it requires mentioning. This is the mud piles mnemonic. I'll run through it briefly. M is for methanol, U for uremia, D for diabetic ketoacidosis, P for paraldehyde, I is variably for INH, iron, intoxication, infection, or essentially whatever you want it to be for. L is for lactic acidosis, E for ethylene glycol or ethanol, and S for salicylic acid. So that's the differential diagnosis, sort of. There are a number of reasons that I don't like this mnemonic, which I won't get into here in any detail, but take my word for it that it's not very good. So let's get rid of mud piles. In 2008, several physicians in Lancet recommended a new elevated gap acidosis mnemonic, Goldmark. G is for glycols, O for oxoproline, L for L-lactate, D for D-lactate, M for methanol, A for aspirin, R for renal, and K for ketoacidosis. This is certainly an improvement. Another mnemonic that is used frequently, possibly more so in emergency medicine than in internal medicine, is COLT. K for ketoacidosis, U for uremia, L for lactic acidosis, and T for toxins. I personally really like this because it's short, to the point, and gives a more appropriate level of emphasis to the 3 most common diagnoses. At this point, I'm going to talk about each diagnosis on the differential in some detail. As I said at the beginning, there will be a fair amount of biochemistry. This is not for you to memorize, but rather to help you understand why certain diseases result in the specific types of elevated gap acidoses. I'll start with the most important etiology, lactic acidosis. So where does lactate come from? Here is a basic schematic of the formation of lactate. It starts with glucose, which undergoes the multi-step process of glycolysis to form pyruvate, along the way generating a few ATP and reducing NAD to NADH. Under normal circumstances, pyruvate is converted into acetyl-CoA with the help of thymine and some more NAD. Acetyl-CoA can then enter the citric acid cycle, also called the Krebs cycle or TCA cycle, where it converts chemical energy into something that can be used by the electron transport chain to generate many ATP in a process known as oxidative phosphorylation. All of these steps here require the presence of oxygen and functioning mitochondria. In some circumstances, however, pyruvate is redirected elsewhere. For example, in anaerobic conditions, there is inadequate oxygen to allow the citric acid cycle and electron transport chain to function. There are also places where mitochondria aren't found, such as red blood cells, and circumstances where mitochondria are not functional, such as cyanide poisoning. In these circumstances, pyruvate is reduced into lactate, with the catalytic assistance of lactate dehydrogenase. This reaction oxidizes NADH back to NAD, which can then be recycled in the process of glycolysis. That may be where lactate comes from on a biochemical scale, but where does it come from and go to on a more anatomic scale? Anatomically speaking, lactate commonly comes from three locations. First, as just mentioned, red blood cells which lack mitochondria and therefore require the formation of lactate. This is actually an interesting phenomenon since it means that RBCs are incapable of using the oxygen they are responsible for delivering. It also means that a small amount of lactate in the blood is always present. Second, whenever cells are either starved from oxygen or have mitochondria that for some reason aren't working properly, they produce lactate. Finally, in exercising skeletal muscle, production of NADH exceeds the oxidative capacity of the electron transport chain. The increased NADH to NAD ratio kinetically favors reduction of pyruvate to lactate. Now once lactate is formed, what happens to it? Most will travel to the liver, where it will be reconverted back into pyruvate. Some pyruvate will then enter the citric acid cycle, while some will enter the process of gluconeogenesis and be transformed back into glucose, at which point it will re-enter the systemic circulation. This is known as the Cori cycle. An alternate fate of lactate is filtration in the kidneys and elimination in the urine. This is usually only relevant once the blood lactate levels exceed a certain threshold, commonly believed to be about 5 millimoles per liter. At first, this was believed to be the whole story. However, in recent decades, we have begun to realize that there are a couple of additional potential sources of lactate. First, in some patients with bacterial overgrowth and high glucose delivery to the colon, intracolonic bacteria can produce excessive amounts of lactate, which can be absorbed through the gut wall. This condition, known as D-lactic acidosis, will be discussed in a minute. In addition, certain malignancies can produce lactate themselves for reasons which are not fully known. The malignancies most commonly implicated in this are lymphoma, leukemia, and multiple myeloma. There are a fair number of medications and toxins that have been associated with lactic acidosis. The known mechanisms are too diverse to review in any detail in this lecture, but they generally involve disruption of oxidative phosphorylation either by direct enzyme inhibition or by more general disruption of mitochondrial function. I will discuss ethanol and the toxic alcohols later in this lecture, and carbon monoxide will be discussed in lecture 19, which will be dedicated to the oxygen saturation gap. The astute viewer might have noticed that there is one medication that is conspicuously absent from this list, metformin. Metformin has long been attributed as the cause of many cases in the literature of lactic acidosis, and I want to spend a couple minutes talking about it. Metformin is a biguanide, which are a class of diabetes medications which work through an unknown mechanism to reduce gluconeogenesis by the liver. They have long been thought to cause lactic acidosis as a side effect, one that was most prominently seen in patients with chronic kidney failure, heart failure, and hepatic dysfunction. This belief was probably the consequence of a superficially similar medication, fenformin, being linked to lactic acidosis and subsequently pulled from the market in 1977. However, it has become clear with time that the concern over metformin seems largely, if not solely, based on the unjustified connection to fenformin, along with anecdotes and isolated case reports. In 2010, a Cochrane review was published that examined 347 separate studies of metformin, each of which involved some form of monitoring for lactic acidosis. These 347 studies included 70,490 patient years of metformin use. Many of these patients had conditions generally considered to be contraindications for metformin, and one trial even explicitly included only patients with renal insufficiency. The results? Not a single case of lactic acidosis was reported. Not one. While there have been hundreds of individual case reports implying or asserting a patient developed lactic acidosis as a consequence of metformin use, almost all of these patients had significant comorbid conditions that could provide alternative explanations as to the cause of the underlying acidosis. The incidence of lactic acidosis among diabetics on metformin is likely identical to that among diabetics not on metformin. This study is particularly convincing given its source is the Cochrane collaboration. For those of you not familiar with Cochrane reviews, I'll just say that they have a strong history of published, independent, high-quality work that investigates the evidence for or against a particular intervention. Their default conclusion is usually that there is not enough evidence to argue for or against anything at all, and that more research is needed before making a definitive statement. Therefore, when the Cochrane authors write, quote, "There is no evidence from prospective comparative trials or from observational cohort studies that metformin treatment increases the incidence of lactic acidosis compared with other anti-hyperglycemic treatments," I am convinced. There certainly remains much skepticism in the medical community about this issue. Of particular concern is whether metformin can lead to lactic acidosis during an episode of acute kidney failure, as well as whether it should be withheld for 48 hours before and after administration of IV contrast. There is insufficient evidence available to comment currently on those two questions. D-lactic acidosis is a relatively unique form of lactic acidosis that occurs as a consequence of lactate having two enantiomers. The L enantiomer is the common form which is produced in humans, primarily via the reduction of pyruvate by lactate dehydrogenase. There also exists the mirror image of L-lactate, which is D-lactate. D-lactate does not normally occur in the body, but can be produced by colonic bacteria in patients who have undergone either jejunal ileal bypass or extensive resection of small bowel. In these patients, unusually high amounts of carbohydrates reach the colon, where the bacteria there can metabolize it into D-lactate, which is then absorbed through the gut wall. Unfortunately, lactate dehydrogenase, normally responsible for catalyzing lactate's oxygenation back into pyruvate within the liver, does not recognize D-lactate. Therefore, D-lactate accumulates as it is slowly eliminated via the kidneys or metabolized without the benefit of an enzyme catalyst. Many patients who have undergone significant resections of the small bowel have asymptomatic mild D-lactic acidosis. When symptoms occur, they are largely nonspecific, but always include altered mental status, with a consistent subjective observation that affected patients appear drunk. The labs in an affected patient will reveal an elevated anion gap acidosis after eating that resolves with fasting. Since standard assays for measuring lactate actually utilize lactate dehydrogenase, they are specific for L-lactate. Thus, these patients initially appear to have normal lactate levels. A special assay that utilizes D-lactate dehydrogenase exists, but it is not readily available at most hospitals. There is a popular system of classifying lactic acidosis known as the Cohen-Woods classification, which divides etiologies into type A and type B. In type A, there is evidence of tissue hypoperfusion, such as that seen with shock, profound hypoxia, acute limb-ischemia, or bowel infarction. In type B, there is no hypoperfusion. Type B has further been subdivided into B1, which is lactic acidosis secondary to another medical disorder, most commonly hepatic or renal failure or malignancy. B2 is lactic acidosis secondary to medications or toxins. And B3 is that secondary to inborn errors of metabolism. I'm not personally a big fan of this system in that it doesn't really feel intuitive to me. I prefer thinking about lactic acidosis like this. There is usually a problem with increased production of lactate. This could be because of problems with oxygen delivery, as you would see in shock, ischemic limb, bowel infarction, severe hypoxemia, and carbon monoxide poisoning. Alternatively, this could be because of problems with oxygen utilization, as with hereditary enzymatic defects, mitochondrial toxins, or thiamine deficiency. In rare circumstances, lactate can be produced from tumors or produced on account of increased motor activity. Instead of increased production, there could be a problem with decreased clearance, as seen in hepatic or renal failure. Because the kidneys aren't a significant source of lactic clearance until lactate levels are already high, it means that kidney failure in the absence of any other mechanism will not be sufficient to generate a lactic acidosis. It will only make a lactic acidosis from another cause a bit worse. Finally, lactate levels can be elevated due to GI absorption, as seen in D-lactic acidosis. Next, I'll talk about ketoacidosis. Ketoacids, also known as ketone bodies, are small compounds synthesized by the liver to be used as alternate fuel by cells during periods of relative glucose deficiency. Acidosis caused by the presence of ketoacids is well described in three situations: diabetes, where the condition is usually known as diabetic ketoacidosis or DKA, starvation, and chronic alcoholism. Ketoacidosis from both diabetes and alcoholism is commonly found in conjunction with lactic acidosis, as well as a mild metabolic alkalosis from vomiting, both of which can complicate the ability to make a diagnosis. To understand why these three situations produce ketoacids, as well as appreciate an important limitation of making this diagnosis, I'll need to briefly review the formation of ketoacids. Formation of ketoacids requires lipolysis of triacylglycerols in adipose tissue. This step is inhibited in the presence of insulin and stimulated by epinephrine, growth hormone, cortisol, and glucagon. The influence of regulatory hormones at this point is the reason why diabetics lacking insulin or in a state of physiologic stress can develop DKA. Also, during fasting states, insulin levels are low and glucagon high, which would also drive this process. The free fatty acids travel in the blood bound to albumin. They can be taken up by most tissues and directly oxidized for energy. In the liver, however, excess acetyl-CoA that is derived from beta oxidation of those fatty acids and not utilized in the citric acid cycle is diverted into the formation of acetoacetate. Some acetoacetate undergoes spontaneous breakdown into acetone, which is responsible for the fruity smell sometimes detected on the breath of patients with severe DKA. Acetoacetate can also be enzymatically reduced to beta-hydroxybutyrate. Beta-hydroxybutyrate is the predominant ketone formed during states of ketoacidosis, particularly in alcoholic ketoacidosis, on account of an unusually high NADH to NAD ratio. Unfortunately, the standard nitroprusside assay, which is used by most labs to detect the presence of ketone bodies, only detects acetoacetate and acetone, which explains why there is a relatively high false negative rate with urine and serum tests for ketones. To reflect this type of uncertainty, some labs have stopped routinely reporting the presence or absence of ketones in the urine and no longer report serum ketones as a titration threshold, but rather as either present or absent. Beta-hydroxybutyrate can be measured directly, but this is often a test that needs to be submitted to an outside lab, and therefore the result does not come back within a clinically useful time frame. As a quick point on terminology, while there are 3 ketone bodies, only one of them is actually a ketoacid. Acetone and acetoacetate are both ketones, but beta-hydroxybutyrate is not. While beta-hydroxybutyrate and acetoacetate are both acids, but acetone is not. Therefore, the term ketoacid only really appropriately applies to acetoacetate, even if common usage it refers to all 3 compounds. In alcoholics, there is an additional complicating biochemical pathway, which is the breakdown of ethanol itself. The first step in this process is the oxidation of ethanol to acetaldehyde, which is catalyzed by the important enzyme called alcohol dehydrogenase. This oxidation converts NAD to NADH. Remember from the previous diagram that a relatively high NADH to NAD ratio helps to drive conversion of acetoacetate to beta-hydroxybutyrate, leading to high levels of the latter in alcoholics with ketoacidosis. The next step in ethanol metabolism is conversion of acetaldehyde to acetate, which is assisted by an enzyme called aldehyde dehydrogenase. Finally, acetate is converted into acetyl-CoA, at which point it can either enter the citric acid cycle and provide energy for the generation of ATP. This is how ethanol can provide a major source of calories for alcoholics. Alternatively, the acetyl-CoA can be used as a precursor for ketoacids, as we just saw. There is an important connection here between ketoacidosis and lactic acidosis, which increases the propensity for alcoholics to develop the latter diagnosis. The connection concerns the possible fates of pyruvate. Pyruvate can either be oxidized to form acetyl-CoA, which will either enter the citric acid cycle or be converted to ketoacids. Alternatively, pyruvate can be reduced to form lactate. The former reaction requires NAD and converts it to NADH, while the latter reaction requires NADH and converts it to NAD. Thus, one of the major determinants about whether pyruvate enters the citric acid cycle or is diverted into the formation of lactic acid is the relative concentrations of NAD and NADH. As ethanol metabolism results in the production of NADH, this helps to drive this balance more towards lactate than normal. When you also consider that most alcoholics have some degree of hepatic dysfunction and that the liver is responsible for most of the clearance of lactates, you will hopefully appreciate why the development of lactic acidosis in alcoholics is so common, even in the absence of tissue hypoperfusion. Renal failure. The elevated anion gap metabolic acidosis frequently seen in renal failure occurs for two reasons. First, there is a failure to excrete hydrogen ions in the kidney. This is due to decreased excretion of ammonium ion and decreased excretion of titratable acids, predominantly phosphoric acid. The second reason is the accumulation of unmeasured anions. These include phosphate, sulfate, urate, and hippurate. Interestingly, there is only partial overlap between the cause of the acidosis and the cause of the anion gap, which helps to explain why patients with early renal failure may have only a non-gap acidosis and later on develop a mixed gap and non-gap acidosis. The anion gap rarely exceeds 20 milliequivalents per liter even in advanced renal failure, so seeing a gap of this severity should always prompt an investigation for an alternative explanation. Next are the toxic alcohols, methanol, ethylene glycol, and propylene glycol. Starting with methanol, it has various industrial uses, is found in some windshield wiper fluid, antifreeze, and paint remover. Although it's commonly taught that methanol poisoning is common in alcoholics who are using methanol in place of ethanol, I personally believe the frequency of this is extremely small for the simple reason that ethanol is so much easier to obtain. Where methanol poisoning is seen, however, is accidental ingestions and in psychotic patients. It can also be seen in suicide attempts, but drinking paint remover seems like such an unpleasant experience. I also have to believe this is relatively rare. Methanol can also be inhaled or directly absorbed through the skin, which can be a source of industrial contamination. Symptoms of methanol poisoning include vision loss, photophobia, abdominal pain, confusion, and lethargy. To briefly summarize the metabolism of methanol, it first undergoes oxidation to formaldehyde with the assistance from alcohol dehydrogenase, the same first step as with ethanol metabolism. As all methanol is broken down into formaldehyde, it might be assumed that formaldehyde toxicity has a very similar presentation. However, as formaldehyde is highly volatile, human exposure is usually from inhalation, and thus it predominantly causes pulmonary symptoms. The next step in the metabolism of methanol is further oxidation to formate or formic acid under regulation of the enzyme formaldehyde dehydrogenase. It is formic acid that is actually responsible for both the increased anion gap acidosis as well as all of the pathology that methanol toxicity causes. Finally, formic acid is broken down into carbon dioxide and water, a reaction which requires the presence of tetrahydrofolate. Therefore, it might seem logical that patients who are folate deficient are more prone to methanol toxicity, and that folate administration might be a way to treat this condition, but to the best of my knowledge, neither has actually been proven. Ethylene glycol toxicity shares a number of features in common with methanol poisoning and utilizes very similar biochemical pathways. Ethylene glycol is a colorless, odorless, but sweet compound that is found in antifreeze and liquid coolants. Its sweetness is one of the reasons poisoning from it is disproportionately present in children and animals. The symptoms of ethylene glycol poisoning is usually broken down into 3 stages. First comes confusion within 12 hours of ingestion. Heart failure, myocarditis, and pulmonary edema develop at about 24 hours. And acute kidney injury occurs 24 to 72 hours after ingestion. As we will see with methanol in a few minutes, An understanding of the metabolism of ethylene glycol is important in understanding key features of its presentation. As with all of these alcohols, the first step is oxidation by alcohol dehydrogenase. In this circumstance, the result is glycoaldehyde. Glycoaldehyde is further oxidized by aldehyde dehydrogenase to glycolate. Glycolate is one of the direct contributors to the elevated gap acidosis seen with ethylene glycol. However, it also impairs cellular respiration at the mitochondrial level and thus results in a concurrent lactic acidosis. Finally, after several additional steps, glycolate is metabolized into oxalate. Oxalate forms complexes with calcium, and these complexes are deposited into the kidney, heart, brain, and lungs, and is responsible for all of the pathologic features not attributable to the lactic acid. Ethylene glycol toxicity is diagnosed from levels directly measured in the blood, but strong supporting evidence includes the discovery of calcium oxalate crystals in the urine, which can be seen on light microscopy, and which is likely to be quicker to obtain than an ethylene glycol level. Antifreeze, which is the most common source of ethylene glycol poisoning, usually also includes fluorescein, added to help trace the source of leaks in automobiles. Fluorescein, when ingested by humans, is eliminated via the kidneys. As a consequence, there is a long-held belief that looking for fluorescence when shining a UV light on urine can be helpful in making the diagnosis. This particular photograph is from a case in the New England Journal of Medicine. Urine from a patient with ethylene glycol poisoning is on the left, and a normal control on the right. Although this sounds like a cool and interesting down and dirty bedside technique, there are actually a number of concerns that this is a poor diagnostic test. There is at least one high-quality study that found, on average, there was no significant difference in qualitative or quantitative fluorescence in normal urine and in urine to which fluorescein was directly added. There is, however, a type of lab error that may prove helpful in making an early diagnosis of ethylene glycol toxicity. It's a consequence of the fact that there exist significant structural similarities between lactate and the ethylene glycol breakdown product of glycolate. The method that some point-of-care analyzers utilize will confuse glycolate for lactate and report an erroneously high lactate level. This is best described with the Radiometer 700 point-of-care analyzer. Lab analyzers, on the other hand, utilize a completely different method for measuring lactate, one which is not susceptible to this error. Also, point-of-care testing with an iStat ABG analyzer also does not appear susceptible to this error. Therefore, a large discrepancy between lactate levels simultaneously measured by different analyzers, colloquially known as a lactate gap, should raise suspicion for this diagnosis. The final toxic alcohol to talk about in detail is propylene glycol. This is used as a solvent for a number of IV medications, including lorazepam, phenobarbital, diazepam, and phenytoin. The typical presentation of propylene glycol toxicity is the onset of renal failure and an unexplained lactic acidosis in a patient who has been on continuous infusion of IV lorazepam for at least several days. Quickly, propylene glycol is oxidized first to lactaldehyde, and then again to lactate, thus the lactic acidosis. Eventually, the lactate is cleared by conversion back into pyruvate. An acceptable level of propylene glycol administration has not been formally defined, but commentary in the literature recommends a limit of 69 grams per day in patients with normal renal and hepatic function, which is the equivalent of 7 milligrams per hour of lorazepam. Other drugs are not infused at high enough rates to lead to propylene glycol toxicity by themselves, but will contribute to this problem if combined with IV lorazepam. Here is a summary of the metabolism of simple alcohols in the body. The first step is always oxidation with alcohol dehydrogenase to form an aldehyde, and the next step is further oxidation to form a carboxylic acid. It's this carboxylic acid that causes most of the pathology seen with toxic alcohols, with the addition of oxalate, which is also very problematic. An important connection between these pathways that is clinically relevant concerns the fact that the affinity of alcohol dehydrogenase for ethanol is greater than that of methanol or ethylene glycol. Historically, this has been taken advantage of in treating methanol or ethylene glycol poisoning with an ethanol infusion, as this will slow down metabolism of the more toxic alcohols into their dangerous carboxylic acid forms. A newer alternative agent to ethanol is a drug called fomepizole, which is a competitive inhibitor of alcohol dehydrogenase and which is generally considered safer than ethanol infusion, but is not available in all facilities. Before we leave the topic of toxic alcohols, I should discuss the serum osmolar gap, which is frequently used to identify the presence of these compounds. Serum osmolality is predominantly determined by sodium, bicarbonate, chloride, glucose, and urea. It can be estimated by taking 2 times the serum sodium and adding the BUN in milligrams per deciliter divided by 2.8 and the glucose in milligrams per deciliter divided by 18. The osmolar gap is the difference between the measured osmolality and the calculated osmolality. There is normally a small gap, but accumulation in the serum of compounds of low molecular weight, such as alcohols, will raise the measured serum osmolality above that calculated by the above equation. Small osmolar gaps are frequently seen in critically ill patients, but are usually less than 20 milliosmoles per liter. Thus, a gap greater than 20 strongly suggests the presence of an unmeasured osmol, particularly in alcohol. This calculation is helpful because many labs will be able to result a serum osmolality faster than a serum methanol or ethylene glycol level. General indications for determining the serum osmolar gap include suspected poisonings with an unknown toxin, an elevated anion gap in the presence of a normal lactate, ketones, and renal function, unexplained altered mental status, particularly in an alcoholic or child, and periodic monitoring for patients on high doses of IV lorazepam. There are a few compounds that can cause an elevated osmolar gap without necessarily causing an elevated anion gap acidosis. These include ethanol, which is by far the most common cause of an osmolar gap, isopropyl alcohol, which is found in some brands of rubbing alcohol, as well as the form of alcohol in most alcohol swabs, diethyl ether, which is an industrial solvent that was used as an early anesthetic in the late 19th and early 20th centuries, and finally mannitol, used to induce an osmotic diuresis or to reduce intracranial pressure in patients with certain neurologic catastrophes. Before I finally move off of toxic alcohols, there is one important limitation to using the osmolar gap in methanol poisoning, demonstrated by this diagram for a patient who has had a single acute episode of methanol ingestion. The concentration of methanol as a function of time is shown here in blue. As methanol goes through its metabolism, formic acid levels, which are initially very low, suddenly rise up after a period of time, before dropping off as the rate of its breakdown starts to exceed that of its production. If you remember, I said that formic acid was the source of the elevated anion gap acidosis. So it starts low and with time starts to rise. Unfortunately, the source of the elevated osmolar gap is the methanol, which starts high and becomes low with time. Therefore, there is a significant chance that the osmolar gap and the anion gap will not both be elevated at the same moment in time, which is unfortunate since it is the combination of the two which is classically taught to be suggestive of this diagnosis. Furthermore, the likelihood of a patient having symptoms is based on the formic acid levels, so symptoms may not even develop until the osmolar gap has returned to normal. The bottom line is to never rule out methanol ingestion on the basis of a normal osmolar gap. So I'm finally done with alcohol, and I promise we are almost through the etiologies, just a few very quick ones left. Next is toluene. Toluene is an aromatic hydrocarbon commonly found in glues, adhesives, and paint thinner. While there are many organic solvents that are available for abuse, toluene has among the highest abuse potential and is particularly common among children and adolescents where they get exposure from sniffing glue. It has a complex and incompletely understood effect on neurochemistry, but at least partially acts as an NMDA receptor antagonist similar to PCP, nitrous oxide, and ketamine, which explains its prominent acute effects of euphoria, loss of inhibition, and amnesia. In higher doses, it can result in slurred speech, ataxia, seizures, and coma. In chronic abuse, patients can develop cerebellar dysfunction and dementia, as well as RTA or renal tubular acidosis, profound hypokalemia, and renal failure. Next is the most recently discovered cause of an elevated anion gap metabolic acidosis, a naturally occurring metabolic intermediary called 5-oxoproline. 5-oxoproline, also known as pyroglutamic acid, is part of an interesting metabolic derangement seen almost exclusively in chronic acetaminophen use, which blocks production of glutathione. Additional risk factors for developing oxoprolinemia include advanced age, malnutrition, chronic illness, and alcoholism, all of which are associated with low glutathione levels. The symptoms and signs of oxoprolinemia are the nonspecific consequences of a severe metabolic acidosis. Diagnosis requires an organic acid screen of the urine and/or serum, which can take weeks to be resulted. To understand how chronic acetaminophen use leads to high levels of 5-oxoproline, it's necessary to give a very brief overview of the incompletely understood gamma-glutamyl cycle. If you've already had your fill of biochemistry, please feel free to skip ahead about 90 seconds. The gamma-glutamyl cycle is a sequence of pathways thought to be important in a variety of metabolic functions, including transmembrane transport of amino acids and breakdown products of various xenobiotics, that is, the breakdown of compounds not normally produced or processed by the body. I will skip most of the specifics of this cycle, but there is one key enzymatic step to be aware of here, where gamma-glutamyl cysteine synthetase catalyzes the conversion of glutamate to gamma-glutamyl cysteine. Activity of this enzyme is usually under negative feedback from glutathione. However, in patients on chronic acetaminophen, glutathione levels are reduced. This removes the negative inhibition, leading to excessive gamma-glutamyl cysteine, which exceeds the capacity of the body to convert it into glutathione, so instead it gets shunted through another pathway that is normally used only minimally that converts it back to 5-oxoproline. Since conversion of 5-oxoproline to glutamate is relatively slow, 5-oxoproline begins to accumulate. At least, this is the current theory as to how this happens. The last etiology, and definitely the least, is paraldehyde. As I mentioned earlier in the lecture, paraldehyde is actually part of the mud pilose mnemonic, but no one actually uses paraldehyde anymore, so this is really just of historical interest only. However, because so many people will still mention it on the differential diagnosis without really thinking it through or knowing what exactly it is, I just want to spend just a very fast minute talking about it. So, what is paraldehyde? It is a sedative and anticonvulsant that was previously used as a sleep aid and to treat delirium tremens. Usage dropped off in the 1960s and 70s as safer alternatives such as benzodiazepines became more popular. It is no longer manufactured in the United States, and the mechanism for inducing metabolic acidosis was never actually determined. I'm going to return now to the modern mnemonics that will help you remember the etiologies of an elevated gap acidosis. They are Goldmark and Colt. To remind you one more time, Goldmark is for glycols, oxoproline, L-lactate, D-lactate, methanol, aspirin, renal, and ketoacidosis. And Colt is for ketoacidosis, uremia, lactic acidosis, and toxins. The last thing I will review is a general approach or algorithm to diagnosing the etiology of an elevated anion gap metabolic acidosis. First step, always be sure the anion gap is adjusted upwards for hypoalbuminemia. Please see Lecture 5 for details on how to do that. Next, check the ABG to confirm that the patient doesn't just have an elevated anion gap and low bicarb, but actually has a metabolic acidosis as well. If there is no acidosis, you should consider causes of an elevated anion gap that don't cause an acidosis. These include severe hyperphosphatemia and the presence of an anionic paraprotein. Assessment of the pH will also help to assess the physiologic severity of the acidosis, as well as look for concurrent acid-base derangements which can be of assistance in determining the underlying etiology. Once an actual acidosis is confirmed to be present, check lactate and ketone levels, as these are the most common causes of an elevated anion gap acidosis. If lactate is elevated, assess for the presence of hypoperfusion. If hypoperfusion is present and systemic, the anion gap acidosis is likely a consequence of shock. If there is evidence of regional hypoperfusion, then the cause of lactic acidosis is related to that. If there is an elevated lactate but no hyperperfusion anywhere, you should strongly consider a medication side effect, toxic ingestion, or lactate-producing tumor. At this point, if there is any altered mental status or a history that is potentially compatible with toxic ingestion, a urine tox screen, salicylate and acetaminophen levels, and an osmolar gap calculation are all indicated, even if it seems that lactic acidosis is the sole cause of the acidosis you're seeing. If instead of an elevated lactate, ketones are present, and if the glucose is greater than 250, the patient likely has DKA, whereas if the patient is a heavy alcoholic, then alcoholic ketoacidosis is the probable diagnosis. If both lactate and ketones are normal, look at the renal function. A GFR less than 40 and anion gap less than 20 suggests that renal failure alone might be the explanation. However, if either the GFR is greater than 40 and or an anion gap is greater than 20, check the osmolar gap. If that is greater than 20, you may be dealing with a toxic alcohol. If the osmolar gap is less than 20, consider rare etiologies as well as a late presentation of methanol poisoning. The absolute last point to make here is that the etiologies for an elevated gap acidosis are absolutely by no means mutually exclusive. It is, in fact, quite common for these to coexist in the same patient, which can impinge in our ability to figure out what's going on. So that's it for the etiologies of an elevated gap metabolic acidosis. If you're still with me at this point, I applaud your thirst for knowledge and hope that you continue on to Lecture 9, which will cover normal anion gap acidoses, and which I promise will contain much less biochemistry.